talk today will be on suicide, a real threat among doctors and medical students. So let's take a look at this first headline, so to speak. Doctors grapple with high suicide rates in their ranks. So this is from Scientific American. The next one, suffering in silence, the scourge of physician suicide. The families are allowed to say it's hard, but the physicians aren't. And this one is from Medscape, something very familiar to us. Physicians experience the highest suicide rate of any profession. So physicians, among all professions, have the highest rate of suicide. Physicians are 2 times more likely than the general population to have completed suicides. It's higher even than in the military, where cases of post-traumatic stress syndrome is known to occur. And ironically, untreated or undertreated mental illness is the cause of these suicides, even if for doctors, mental health treatment is literally just next door for them. So for today's discussion, we'll be talking about the doctor's suicide story, the phenomenon of suicide, and what we can do. So hopefully within 15 to 20 minutes, we'll go through these. So before we start, is anyone here familiar with BRP? Has anyone heard of this among your clerk or intern or resident friends? Has anyone heard of their resident friend or friend of friends who encountered a BRP? Or does it sound familiar? Sige sa'yo, familiar. So, what do you think does it stand for? Brief reactive psychosis. So, what do they mean when a resident has a BRP?
Hindi na alam yung nangyayari sa kanya.
Sobrang stress na di na niya alam yung nangyayari sa kanya. And then what's the usual story of a resident who has a BRP? Usually they just disappear, but they don't report to work. Then sometimes they show up again. Then the other residents usually hate them because they left a lot of work. Or sometimes they never show up again. Then you just see their pages, their names in Moonlight Bay in Facebook looking for gigs because they're not residents anymore. So it's brief reactive psychosis. It happens in our everyday lives. We use that term, nag-BRP siya. And it somehow signifies the level of stress that our residents would encounter. It seems trivialized, but it's actually part of our everyday lives as doctors to have so much stress. So the doctor's suicide story. First, the UP trap. UP is sort of a catching pool for, on one side, they say the best and the brightest. Those who have, it's the cream of the crop, so to speak. Those who have passed the UPCAT, those who are the top of the high school batches. But on the other hand, being on top also has its price. These are also probably the more competitive ones, those who have sacrificed the most, those who have set their emotions aside the most, those who have been pressured the most. So these are actually students who have somehow paid the price for excellence to begin with. The med school trap. So people who go into med school are very idealistic. They want to help, but there's also another side to it. These are people who tend to be sacrificial. They tend to be highly idealistic, then get disillusioned once they get into med school, realizing they can't do everything. They get frustrated seeing what it's really like in the real world with limited supplies, medical supplies, with patients or families not really cooperating with them, with things not being in their total control, things not going the way it should be like in the textbooks. So that's the med school trap. Master of disguise. So doctors are masters of disguise. They can and sometimes should pretend that everything is all right, even if it's not. Patients first is another of the doctor's story. They should put the patient's welfare first, even if they're already suffering. Glorified stress. If you're not doing anything, then you must be lazy. Ang dami mong time, di ba? Sabi nila, if you have time to sleep, then you have so much time in your hands. Or if you're not toxic, then you must not be doing enough. Somehow that's the life of medical students or doctors. You can always do better. You must be stressed or you must be harassed in order to say that you're reaching the threshold of enough. Doctors, the hardest patients. Doctors find it really hard to accept help. Doctors find it so uncomfortable to accept advice, to rest, to take a day off, to actually take medicines, or even have a checkup. So all of these are stories of being a med student, being a doctor. People somehow expect us to be perfect, and we expect that from ourselves. We always aspire for being ideal. We have to be self-sufficient. It's so hard to ask for help, while it's so easy to give help. We always have to be tireless, so self-sacrificing, to the point that we deny our feelings of being tired, of being angry, of being disillusioned, and we always have to be on top. For non-doctors, this can be labeled as grandiose delusions in psychiatry. But for doctors, we live out these grandiose delusions in our daily lives. And of course, living out grandiose delusions into reality can be a very psychotic experience. And it takes a toll on doctors. So the suicide story can start with stress. Stress can involve pressure from inside and from outside. And we know how pressure builds in the lives of medical students and doctors. It can also come from a sense of being disconnected from our peers, from our family, from our friends. It can be an imbalance of work and play and rest. And it can come from a sense of purposelessness or simply not liking what we're doing. All of those are sources of stress. And stress, when it's chronic and it's uncontrolled, can evolve into burnout. Burnout can be classified into 3 components from Maslow's burnout inventory. First is emotional exhaustion, being too tired in such that even the simplest of tasks can wear you out so much. Even just getting out of bed is tiring. Even talking to someone is tiring. A simple extra task is tiring. Or if something goes not in the way you planned it, that's very tiring already. It frustrates you so much. Everything is tiring, frustrating, it's irritating. Depersonalization. Nothing seems important to you anymore. Nothing is meaningful anymore. Nothing is truly worthwhile to you anymore. Everything is just a requirement you have to finish. And the poor sense of competence or accomplishment, you feel that nothing is within your control or you're achieving nothing. You feel like you're not reaching to your standards or you're not doing anything relevant. And the combination of the three is actually the syndrome of burnout. So burnout in the University of Washington, according to Martini and colleagues, is from 50%, ranging from 27 to 75. 75% among residents in obstetrics and gynecology, 63% in internal medicine, and it's lowest in family medicine, but still quite high at 27%, or at least 1/4 of them. So it's a real problem in medical practice. So imagine around half of the doctors actually feeling emotionally exhausted, depersonalized, and not feeling they're accomplishing. And in PGH, this is a study by Alonzo, a pedia resident during that time. Compassion fatigue is at 23% of the residents and burnout at 26%, meaning 1/4 of the residents, those who were not burned out enough to answer anyways, felt burned out. So yung iba, too burned out to answer. And from burnout comes depression and anxiety. It's when the state of suffering becomes brain damage. So depression and anxiety can be considered brain damage. So what happens to the depressed brain? The amygdala becomes hyperactive or hypertrophied. The hippocampus becomes smaller. So in result, our emotions run on overdrive. We tend to reason emotionally. We become angry. We become sad so easily. Because the hippocampus, which regulates our emotion, also can't do its job. And also the hippocampus, which is in charge of learning, doesn't function so well. So we can muster the thinking part of our brains. Then there's reduced striatal connectivity and response to reward, meaning the reward system of our brain doesn't work so well anymore. Sometimes, in a last-ditch effort of our brain to keep the reward systems functioning, it resorts to risky behaviors like drugs, like promiscuity, but eventually it fails. The rewards pathway would eventually fail. It's actually called anhedonia, or the lack of pleasure when it already fails. Not in the slide, the prefrontal cortex will also atrophy, thereby actually setting the emotional and cognitive impairments in depression and anxiety, and eventually even the vegetative impairments like problems sleeping, problems with energy, problems with appetite. So bottom line, when the state of suffering already affects even the anatomy of our brain, it becomes depression as a form of brain damage. And one can be impaired enough to be suicidal. And that is the story of a doctor's suicide. So suicide can be explained in many ways. Can be explained cognitively, can be explained neuropsychologically, neuroanatomically, can be explained through personality, through neurobiology. Bottom line is, suicide is composed of many factors. It doesn't just arise right then and there. It takes time to develop. It's not a sudden decision. Suicide is preceded by ideas and feelings, and frequently by mental disorders. People who are suicidal are usually not sure of their actions. In fact, the suicide act is wrought with ambivalence. The same way that someone who is depressed or anxious finds it really hard to think. They're not really sure. So the suicidal act is usually not a clear decision, but something that is done in a way, in an undecided way. Talking about suicide adds to the risk is a myth. You don't put the idea in someone's head by talking about it. In fact, it's the only way to get it out in the open and address it. Suicide is not simply a bad choice. We can see that it's a manifestation of biological, psychological, and social risks. Therefore, we can do something about the suicide problem. For acute suicidality, there are a lot of interventions open. Medications can help, for example, with distress and negativity, for impulsiveness or discontrol, or for confusion, or the difficulty in thinking. Psychotherapy can help for cognitive distortions, for problems with problem solving, issues of self, to help with coping skills, for emotional regulation, or to restore the sense of meaning or purpose. And of course, psychosocial interventions would help, such as in addressing stressors, connectedness, or restoring engagement. And addressing any one of those would actually help the other. For example, decreasing the negativity would help the person cope better, or would help the person become more connected, or vice versa. Helping the person engage or be more connected will actually lessen the distress or would improve issues of self. So even addressing one factor can improve the totality and change the suicide risk. But of course, that's just the intervention part. There's so much more that can be done to promote and to prevent. What we want to do is to work from the bottom up. We want to, first and foremost, create an open environment and mental health awareness so that the suicide story does not happen anymore. So, remedy for burnout. As doctors, we also have to prescribe to ourselves resilience, the practice of faith, the cultivation of self-worth, and the practice of creativity. But of course, we can't do it alone, so we also have to foster support, enhance compassion, and encourage connection. And this is the remedy for burnout. The greatest investment of doctors is really ourselves. And I think that is the missing or the most often neglected dimension of studying in medical school is how to take care of ourselves. But it's also the most important because at the end of the day, what we have to offer our patients is ourselves. So the threat of suicide in medical school and as doctors is real. Take care of yourself, take care of each other, and seek the care you need if it's needed. So in other countries, they have Physician Suicide Prevention Day, and they have Doctors Day. So may this be reminders that, again, the threat of suicide is real, and we should never forget to love ourselves as doctors. Thank you.